Hello, this is Dr. Paul Cottrell, and I'm recording this on January 16th. This is the next video. The first video I did on this little series was the information that came from Miss Taiwan over the last week, just to catch up. Now what we're going to do is we're going to cursory listen to what's going on with these different pathogens. I'm very concerned about Marburg. I'm very concerned about HMPV, Mpox, influenza, avian flu. So I'm concerned about influenza A. I'm concerned about avian flu, H5N1. Currently in New York, there is a surge. I know a lot of people that are sick. Right? So there's a surge of RSV. There's a surge for different types of cold viruses. You have the adenoviruses, you have the rhinoviruses they're happening. There's SARS-CoV-2, there's influenza A floating around. So there's a lot of people that have colds in New York, all right? And a lot of elderly that are getting it, all right? So, just pay attention to that. And that's common in the cold season, that pediatric and geriatric patients have pulmonary issues. The manifestation, though, with these is that it's not just a simple cold. What's starting to happen is it's like it's straddling this bronchitis and pneumonia, all right? So sometimes you get a cold, you get the sniffles, you get the sore throat, you cough a little bit, and boom, you heal after 5-7 days, right? That's what happens when you're healthy, just the common cold. But what's happening is that patients, and the community at large is showing this bronchitis and kind of bronchitis / pneumonia kind of thing going on, and it's lasting. And it kind of like it doesn't want to clear, right? This is a common thing. It's not for everybody, but it is a common thing that's happening in the New York area. So now, why is that happening? Is it just that this cold season is worse than other cold seasons? Well, if you look at the numbers, this cold season is not worse than last year. Last year was better. Let me say that. Let me rephrase that. Last year had more cases, all right? Last year was a worse cold season than this year. So this year it's better in terms of number of cases. The problem comes in is that it seems as though this year it's more lingering compared to last year. So last year's cases didn't linger. You had more cases. So this is what I mean by last year was better. Last year was better in terms of not lingering. This year it's lingering. All right, so why is that happening? Is it immune systems are down? Is it, for either because of external factors, your environment, or internal factors because of your immune system being a little weaker than it should be? That could be a part of it. But, number of cases are, when you look at these different pathogens across the board, the ones that are like the influenza-like cases, the influenza cases, the COVID cases, these are less than last year, but you have the lingering problem. All right, now that could change, but we're probably at the peak. I would say that we're probably at the peak, at least in the New York area. It'll probably start to go down. The weather is still pretty cold. We're mid-January, so I suspect that after January, the peak will be behind us. I would think. It may linger a little bit across the country, but people are getting sick, and there is a lingering effect. And when you do get the bronchitis and the pneumonia, then it takes longer to heal. So just because you feel better, it takes longer to heal. Something that's benign that lasts for about 7 days, and it's not pneumonia, it's not bronchitis, takes about 2 to 3 weeks to heal your body. If you get the bronchitis and pneumonia, you got to add another 3 to 4 weeks to that. So you're talking about almost 2 months from when you get infected to when you fully healed, if you get this bronchitis pneumonia kind of manifestation during the cold season. So just keep that in mind. So in this video, we're going to do a cursory review of the news to figure out what's going on. And there's, different outbreaks to worry about, right? So I want to take a look at what's going on with Marburg in the last week. Okay, so let's listen in on some stuff. Experience luxury in every price that you can imagine.
System. Discover the exceptional with Buick. Buick, exceptional.
Come on, everything cycle.
A suspected outbreak of Marburg virus in northwest Tanzania has infected 9 people, killing 8, according to the World Health Organization. This alarming development comes just weeks after neighboring Rwanda declared its own outbreak of the deadly virus officially over. The Marburg virus is closely related to Ebola. Both viruses are endemic in East Africa and are believed to be transmitted to humans through fruit bats. The recent Tanzanian outbreak has been reported in the Kagera region, which shares a border with Rwanda. The WHO confirmed it received report of the suspected cases on January 10. Symptoms among patients include headache, high fever, muscle weakness, vomiting blood, and severe external bleeding. The outbreak in Rwanda, which ended in December 20, infected 66 people and claimed 15 lives. Its proximity to Tanzania's Kagera region heightens concerns about cross-border transmission.
All right. So we got 8 cases, dead, Tanzania outbreak. Now, I think what's important to mention is a little bit of the history of this. And I've mentioned this, I think, before in a different video, but I'm gonna do it again. All right. Now, I'm not going to read each one of the outbreaks. The first one for Marburg seems to have taken place in 1967 in West Germany and Yugoslavia, and then it goes all the way to this year. All right, so there's been lots of different outbreaks, but I'm going to focus on the big ones in terms of the number of cases. All right, 31 cases for the 1967 outbreak in West Germany and Yugoslavia. In 1998 to 2000, the Democratic Republic of the Congo, 154 cases. 2004 to 2005 in Angola, 252 cases. I'm just mentioning the big ones. Some years it's like onesie, twosies, Uganda, 18 in 2012. Equatorial New Guinea, 40 in 2023. In 2024, Rwanda, 58. And then this Tanzania, 8. So deaths, okay, for the ones that I've mentioned. 7 in 1967, 128 in 1998 to 2000, In 2004 to 2005, 227. In 2012, 9 out of the 18. In 2023, 35. And in 2024, 13. And then this year, 8. So it definitely looks like that from 1967, Marburg has been getting worse. Now the question is why? What kind of mutations are taking place? Don't know. All right, but I have been diving into the different clades, and I have some ideas here that I'll do in a different video. But the point here is that when a big outbreak does happen, and it doesn't happen every year, it's sporadic, the number of cases and the number of deaths are increasing. Okay, especially some big jump happened from 1967 to 1998. Now, what that big jump is, we'll dive into the data and find out. There was another big jump, seems to have happened from 2000 to 2004. Now, is it the same version? We'll have to take a look at it. I'm not sure if the Angola and the Congo are the same version. It's possible, but there seems to be a jump from 1967 to 1998 in terms of severity. Now, I'm going to be doing an overview of Marburg, going over the molecular biology, the genomics, right? The virology. There's a lot there. There's a lot to cover there. We actually know more about the Marburg genome than we do about Mpox. Now, Uganda had 18. Maybe that is just kind of a spillover from other versions, or there's some sort of attenuation that's coming out of the Congo or Angola. Not really sure about that. Probably not. But this Rwanda and Tanzania, 58 cases, 13 died. 8 cases in Tanzania, 8 died. All right. They say 88%. I don't think that they have the number of cases updated. There must have been more than 88. There were probably around 10 or 11 cases. But that's the history. All right. Something happened. So it first was detected outbreaks in 1967, and something big happened in 1998, and another big event happened in 2004, and then another big event happened in 2025. All right. So, and it's in this, all in this region. There's a hot zone with Marburg. Okay. So that's the history. I just thought that was important to restate. I have stated it before, but let's take a look at what's going on here. This is African news 3 hours ago.
Tanzania has denied reports of a suspected outbreak of the deadly Marburg disease in the northwest of the country. The World Health Organization on Tuesday said 9 possible cases were reported last week in the remote Kagera region, adding that 8 of those infected had died. Local residents adapted their behavior on the news. We've refrained from greeting each other by shaking hands, as was the custom in the past. Instead, we greet from distance while continuing to follow the guidance of health experts on how to protect ourselves from this disease. But Tanzania's health minister on Thursday said after samples were tested.
I'm sorry. I said 11 cases with the history, and that the chart wasn't updated. It's 9 cases. So there's 9 cases, 8 deaths.
Suspected cases were found to be negative for the Ebola-like virus, and that the country has strengthened its surveillance systems and disease monitoring as a precaution. News of the suspected cases came weeks after an outbreak of the virus in neighbouring Rwanda was declared over. The WHO had cautioned that the risk of the suspected virus spreading in the region was high, as GETTR is a transit hub to several countries.
All right, now why is Marburg so problematic? It's hemorrhagic. It's very similar to Ebola. All right. Now, should we be worried that the world is going to, turn into some sort of major hot zone, all over the place, and it's going to be pandemonium? No, that's not going to happen. All right. Why? Close contact. The patients die fast. There's high death, and the transmission is, bodily fluids, very close contact. The viruses that that concern me are respiratory. All right. Marburg doesn't concern me for the world population or the developed world or the United States. It does concern me in terms of areas that have poor healthcare, poor sanitation, close to wildlife. And so, regions like Africa are going to be problematic. And there's going to be these outbreaks. All right. The concern is that if there's a mutation that has taken place for Marburg, where it is able to transmit better. Now, here's the problem. Sometimes viruses need to get stronger to be more problematic for stronger, meaning higher affinity or right receptors, be able to replicate better, all this stuff, right? To be able to take hold in the society, to be able to be more of a pandemic issue. Other times, viruses have to attenuate to be problematic. So you can have high death rate, right? But short duration in the population with things like hemorrhagic viruses, Ebola, Marburg. And these patients will get it. Some of them will recover. A lot of them die. It's fast. It doesn't linger. All right. And there has to be that bodily transmission. Now, these cases and hopefully we'll find the video that I listened to last night. A lot of these cases are healthcare workers. So they've been in an environment highly exposed to individuals and then catch it. So their PPE, their protocols may be subpar. All right. But let's get back to the attenuation or a virus that needs to be more supercharged. Viruses like Marburg and Ebola, they're so deadly that it's not going to be all over the world. I'm running out of battery here. Just hold on. Let me just plug it in. Plug it in. So Marburg is a deadly virus, just like Ebola. And because it's so deadly, and it kills the patient off pretty quickly, and it doesn't spread distance-wise really easily. You get these outbreaks and then it dies off really quick. All right. Now, if you're in the zone where the outbreak, it could be problematic, and a lot of people can catch it. We've had cases that were over 200 that I read. What was it? 252 in Angola in 2004, 2005. So you can have these cases that are really bad, but it dies off. But if it attenuates and gets weaker, and it stays in the body longer to allow it for it to spread in larger areas, then it becomes problematic. Now, there's no evidence of that happening yet. Now, maybe what has happened between 1967 to 1998 or 2004 has been some sort of mutation that has taken place. Maybe that mutation is higher affinity to receptors or better fusion proteins. We'll go over the details of Marburg virus. So when it does get into a patient, it just manifests better. Maybe there is some sort of immune suppression capability. I went over this in MPV. Immune suppression is a big part of the mechanism for MPV. So something could have gained affinity or viral load increased because of replication, that once a patient gets infected, it gets worse. That may be the mutations from 1967 to 2004. Or what has happened is that lineage in Angola or Congo has attenuated, and it's weaker, so it doesn't create such a physiological effect early on, and that patient can carry it longer. I don't know. Is it attenuation or is it through some sort of enhancement? Or a little bit of both. Who knows? But the big concept to take away here is that viruses sometimes attenuate and they weaken and become endemic. And if you have a lot of antibodies and people have exposure, it's not that big of a deal for many pathogens. But serious, really, really the highly deadly ones like Ebola and Marburg, if they attenuate, they may actually get worse because they're in a category that they are in the body, they don't last for very long, they kill the patient very quickly. There's no treatment. But if it attenuates and it's hemorrhagic and it's slower to manifest, then it could spread. It could spread in the population easier. And then you'll have more cases. Now, will that be a huge pandemic for the whole world? I don't think so. That's so low probability event. Higher probability events are the mpox issue. Because if that takes hold in a developed nation, there's not many people that have, a big part of the population does not have cross-reactivity to smallpox or mpox in developed nations. In developing nations or poor countries, they don't have any cross-reactivity. So in the population, unless they survived an outbreak. So I'm not too worried of Marburg spreading around the world and causing havoc, but you're potentially going to have more hot spots of breakout, and then a containment, and then it dies out again. Then a containment, then it breaks out, containment, then dies down again. And this is the cycle that's happening in Africa. But when the outbreaks do happen, when they're big, they're like really big, right? They're going in the hundreds. You got the 250 case in Angola in 2004. We had the 58 case last year in what was it? In Rwanda. So keep that in mind. Attenuation of, let's say, influenza. All right, more people will get it, but it's not that bad. Attenuation of Marburg could be very problematic because it's a virus that typically kills you so quickly that if it attenuates and it festers, it may actually be worse in the population. There may be more cases, and then there's more deaths, and blah, blah, blah. Up to a point where if it continues to attenuate, then it becomes more of non-problematic, but we're talking a long time from now. All right. So it depends on where the pathogen is coming from. What's its baseline? Is the baseline kills the patient with quickly? There's high death rate. There's no good treatment for it. Or is the baseline it's mutated? Nobody has antibodies for that particular pathogen. It spreads, and then as it's spreading, it attenuates and it becomes endemic. And most of the respiratory infections are that way. So, just keep that in mind, that core concept. Attenuation all the time doesn't necessarily mean good for mankind. Attenuation of Marburg in a certain time frame may actually be problematic, not beneficial to mankind. Because if Marburg or Ebola can stay in patients longer without killing them, you're increasing the chances of spread in a larger population. So that's a problem. So what's changing from 1967 to 2004? What's changing from 2004 to 2024? Are we seeing an attenuation? Are we seeing an enhancement to something? Fusion protein, spike protein, immunosuppressant capability of the virus of Marburg? Who knows? I don't know. I got to dive into that. We'll find out. But the thing is, attenuation all the time, not necessarily good. That's a key takeaway. It's a key point that most people are not talking about. Okay, so let's continue on with our survey of Marburg. This was 20 hours ago on Citizen TV Kenya.
With Spectrum's easy self-install kit, turn on the anniversary mix. You can feel at home in minutes.
I don't understand. Every single one of these channels I got to recycle.
So they're switching gears altogether. And the Director General of Health, Dr. Patrick Amoth, has assured the country that the Ministry of Health is on high alert following the Marburg virus outbreak reported in Tanzania that has resulted in 8 deaths. Now, Amoth noted that due to Kigera's proximity to Migori and its role as a transit hub, the Kenyan government has implemented protocols for managing public health emergencies. Now, the outbreak in the Kigera region of northwest Tanzania reported just weeks ago after Rwanda declared an end to its Marburg outbreak. Marburg virus is similar to Ebola and is a viral hemorrhagic fever with a fatality rate of 88%. According to the World Health Organization, national rapid response teams have been deployed to support outbreak investigations in Tanzania.
Marburg disease outbreak in the United Republic of Tanzania. Because of the interconnectedness of our region, we are equally at risk, and therefore we have reactivated our systems, including our surveillance, risk communication, infection prevention control.
All right. So it's still 8 cases. It seems to be somewhat under control. This could be just an outbreak, and they'll die down. Africa has a lot of them, but there have been these points in time where there were big outbreaks, and that was in 67, 2000, in 2000, 2004 and 5, and in 2024 and maybe 2025. It's just begun. But this the 2024 cases maybe just spill over into 2025. So there's not a lot of information on this particular issue. Really, there really isn't. Now let's go back. Let's see if we go back a month, do we see anything that was starting? All right, I'm not going to play this because it's 18 minutes long, but your Rwanda 3 weeks ago declared the end of Marburg virus disease cases. So they were able to control it, but then it pops back up in Tanzania. Now remember, Rwanda was the 58 cases from 2024. So that's a data point. Rwanda was able to control it a little bit better. They were able to control the outbreak. Is there a quick clip? No, all these clips from Rwanda are like 38 minutes long, 17 minutes long. I'm not gonna play that. This one, 3 weeks ago, 2 minutes ago. All right, so here's a data point. Okay, so we have Rwanda, 58 cases, Tanzania, 9 cases, and 3 weeks ago, Rwanda saying outbreak over, and Tanzania is just starting. Now, is Tanzania just going to be 9 cases and it's going to die down? It could be. That's possible. Most of the outbreaks are like that in Africa. You know, onesie twosies or maybe 10 and then it dies out. It's possible. But without knowing the genomics of Rwanda's version versus the genomics to Tanzania, we don't really know. What's changing? What's the mutations? These things are mutating. What is happening? That's important. The same thing with HMPV. Understanding the evolutionary mutations of a particular pathogen are really important, right? What's changing? So let's play 3 weeks ago, Rwanda stating, okay, outbreak's over from their 2024 outbreak.
My heartfelt congratulations to the government of Rwanda through the Ministry of Health, specifically you, Honorable Minister, for the exceptional leadership in effectively containing the very first Marburg virus disease outbreak in Rwanda. Your decisive actions, unwavering commitment, and rapid response was instrumental in preventing widespread negative and impact and safeguarding lives. Today, we gather to mark a monumental triumph, the official declaration of the end of the Marburg virus disease outbreak in Rwanda. This is not just a milestone. It is a testament to the indomitable spirit of the Rwandan people, to the strength of country leadership, the bravery of the healthcare workers, and the transformative power of collaboration and partnership. On behalf of WHO and on behalf of all development partners, we are proud to have worked hand in hand with the government of Rwanda and contributed to the achievement of this remarkable milestone in the Marburg outbreak response. Through decisive case management and a comprehensive strategy, loss of life was significantly reduced and community transmission was stopped. As we celebrate, let us enter the new year with renewed hope, strength, and a unified resolve to building a healthier, safer.
All right, so that's a data point. Outbreak, Rwanda, 2024, declared the end of it 3 weeks ago, all right? So outbreak's dying out in Rwanda, but Tanzania is starting to flare up. Now, what is it? Now, my understanding, most of the cases are healthcare workers. So probably what's going to happen in Tanzania is it's just going to die down. But it's really important to get the genomic data and to understand what's going on in 67, what's going on in 1998, 2000, what's going on in 2004, and then all of a sudden 2024, 2025. But again, like I said, I'm not worried about worldwide spread of Marburg. Not at all. Not at all. Why? Because it's so hard to transmit. Patients that get it, it has a high death rate, all right, and it dies out quickly. There's no treatment for it, but and you know, you get these flare-ups, boom, and then it dies down really quick. The problem comes in is that if it flares up and then dies down, flares up and dies down in regions and it circulates, all right, then there's a chance of it attenuating. And when it's attenuating, then it may become more problematic. But that problem is not going to manifest itself in developed nations. It's going to manifest itself first in Africa. So if we start seeing huge cases, huge deaths that continue on, and there is a human-to-human transmission, and again, human-to-human transmission because of this attenuation, then it's more concerning. There's more cases that could have clusters of outbreaks in developed nations if someone was exposed. It has some sort of asymptomatic manifestation because of the attenuation, or a longer incubation period because of the attenuation, and then it spreads in developed nations. But we're talking low probability event here, all right? So I'm not too worried about catastrophe around the world with Marburg at all, not at all. But it'll be problematic in Africa. Now, we got to start talking about some of the other things. Like, I'm concerned about the pox viruses, which is still low probability, high impact. But if it does take hold in a developed nation, because the lack of cross-reactive antibodies, boom, it can be a problem, big problem. Respiratory, huge problem. All right, that's easy to transmit. So when you're talking about the mycoplasma pneumonia, you're talking about SARS-CoV-2 or influenzas that become more problematic to humans, like, let's say, some sort of mutation that takes place on H5N1, then boom, it's a problem again. Now, will there be deaths from influenza that are as high in absolute numbers as, let's say, the Spanish flu? Probably not. Why? Better healthcare in developed nations. And there are quite a few people that have antibodies to something, to influenza. So there's going to be some cross-reactivity, something there. All right, so it'll slow it down. And then with biotech, the advances in biotech are so much more advanced now than it was in 1918. So there's some differences with an influenza outbreak. Now, would it kill a lot of people? Yeah. I suspect that if H5N1 gets to human transmission and has the mutations that I talked about, where you have the truncation of the N protein, you have the honing in on the alpha-2,6 receptor, you have the replicase that's mutated to be able to create higher viral load and have better human transmission, you're talking about 250,000 people in the United States die from influenza, H5N1, in 1 year. Now, that is smaller than than what COVID was. It's about 5 times the worst kind of situation in a normal influenza season. Normal influenza season, you can have a range of anywhere from 12,000 to 50,000 people that die from influenza. So I took the worst case and had a factor of 5. That's my guesstimation for a human-to-human transmission of highly pathogenic H5N1. 250,000 people will die from H5N1 if it goes human-to-human transmission with high fidelity in 1 year. So that's my take. So respiratory infections are far more of a problem than Marburg. If you get Marburg, you probably will die. All right. You get Ebola, you probably will die. The thing is, the chances of getting Marburg or Ebola is so small. Now the question comes in: was this really what's going on in Tanzania and Rwanda? More of a circulating issue, and it's just mutating, and it's just flaring up and then dying down, and this is just kind of a seasonal or annual flare up, or every other year or whatever in Africa? Or is there something new that was released, or something new that is evolved? We don't know if something new has evolved yet, because I don't know too much of like what has changed from what has changed in the version that Tanzania has versus what was the baseline concern variant, which is the Angola. The research that I have read, it seems like they baseline off of Angola. All right, so there's mutations that take place. I have a research paper that I'm going to go over that talks about what has changed. So there has been changes that have been taking place over time. But what's the Tanzania version? I don't know. It hasn't been published that I know of. All right, now I'd have to dive in a little bit more. I've been just diving into this whole Marburg thing for deeper dive just recently. I was more focused on the MPV. I still think MPV is problematic. Marburg, for most people, don't worry about it. You're not going to get it. You're not going to die from it. Areas that have outbreaks, like Angola, like Rwanda, it's going to be problematic over the years. And the question is, will it attenuate and become worse in human populations? Just because, like I said, if it becomes asymptomatic, or there's some sort of a longer incubation period, then you're talking about cases spreading in different areas outside of local regions within Africa. So that's an important feature to understand. But I think we're talking low probability events and not very high impact. MPV, you know what? That's respiratory, that's high impact, high probability. Mpox, at this moment in time, low probability, high impact. Marburg is very low probability, low impact. So, just keep that in mind, that there's the degree of impact and the severity. I'm not concerned at a global level hemorrhagic fever. Just not worried about it. Is there anything else that's popping up? Okay, so that's Marburg. Now, what I'm going to do is I'm going to do another video focusing on the MPV and some of the other respiratory viruses. But that's my take on Marburg. I think it's just at this moment in time, the data is suggesting it's just endemic to the region, right? There's just kind of like this, it's just an outbreak, and then it's going to die down. Many of the cases were healthcare workers. So until you start hearing non-health worker cases, then, it's still, not that problematic. I don't see this spreading to the United States. I don't see this being a worldwide phenomenon at all. But it's important to understand what's mutating with Marburg. All right, is it mutating in a way where it's becoming more attenuated so it can stay in the body longer to be able to spread? That's the question. That's a big question. So hopefully you learned something. I will talk a little bit more about this, some of the details, but I want to do the cursory review of the other pathogens in the next video. Please make sure you subscribe to all my channels. Please ask your social media to follow me. Help support my work by donating. You can donate through Stripe, PayPal, or buy me a coffee on my website, the-studio-reykjavik.com. You can be a paid member to my Patreon channel. Please, that helps support me doing these free videos. I have thousands of videos for free to inform the public. Also, follow my lead. I tell you what I do. Get the products on my store, the-studio-reykjavik.com. Thank you for listening and have a nice day.